Good afternoon, everyone. We welcome you to the first webinar in the Maha Smiles Cleft Care for Every Child webinar series. I would like to introduce Ms. Mamta Carroll, the Senior Vice President and Regional Director Asia from Smile Train India. Over to you, Mamta ma'am.
Hello, everyone. Can you hear me?
We are live.
Yes, ma'am.
Okay. Thank you so much for inviting Smile Train to this webinar. I will share my screen. Can you see my screen?
Yes, ma'am, we can see your screen.
So thank you very much. It gives me great pleasure to welcome you all to this is the inaugural session of a project called Maha Smiles, Cleft Care for Every Child. It's a webinar series in partnership with the Association of Maharashtra Obstetrics and Gynecological Society, which is AMOGS, Science Integra, and our valued CSR partner, Bajaj FinServe. And I welcome all of you here today, and especially Dr. Rajendra Pardesi, President of AMOGS, Dr. Sujata Dalvi, Secretary of AMOGS, Dr. Sujit Konkar, Chairperson, Fetal Medicine Committee, AMOGS, Dr. Padmasini Venkatramanan, Nutrition Advisor for Smile Train, and also Dr. Rashmi Kahar, our moderator for this session, and our valued and long-standing corporate supporter, Bajaj FinServe. From Bajaj, I welcome Dr. Shubhangi, Mr. Akshay Chaudhary, and Sapna. So this project is a very, very special project, and I'll give you a very short kind of background to what this is and why are we all together for this today. So Bajaj FinServe is a true friend of children with clefts, and their sincere intent to make tangible difference in the life of cleft-affected children across India is especially very heartening to know that. And especially in Maharashtra, they've been supporting Smile Train for all of our partners and hospitals in India, but specifically Maharashtra. For the last 10 years, we have been partner. As many of you may know, that 1 in every 700 live births is affected by cleft lip and or palate. And without treatment, these children actually, struggle with feeding, eating, breathing, and speaking. Untreated clefts can also lead to increased ear, nose, throat infections, hearing loss, and other associated problems and dental problems as well. Cleft is also, especially in our country, associated with a lot of superstition, often leading to social stigma. But there's a good news. The good news is that cleft lip and palate is one of the few birth defects or differences that can be completely treated with the help of surgery and associated comprehensive cleft care, such as, speech therapy and orthodontics. In fact, most babies with appropriate cleft care, we can restore normal function with very minimal scarring. This project, let me come back to this project once more, that the objective of Maha Smiles is basically to have these programs specifically for Maharashtra with the intent of, facilitating resources for awareness, getting people together so that spreading the message that this birth difference is completely treatable, and children can be referred to the 10 Smile Train Cleft Care Centers, which are all over Maharashtra, so that appropriate comprehensive cleft care can be given to each and every child. No one is left behind. And as I said, that this is completely being supported by our corporate partners, Bajaj FinServe. So thank you very much. And I will just go into a little more detail in showing you a map here, which basically gives you an idea of where the centers are and how does one go about it. As I said that, we have these free cleft centers. And via this webinar, and I'm taking this opportunity to appeal to each and every member here who's attending this, and go and spread the message even outside this webinar, to help children with clefts lead a healthy life, so that all of these children are referred to our Smile Train centers. Please help us, call us on our toll-free Cleft helpline, which is 1-800-103-8301. And we know we can work together on this. So thank you very much. And I now hand over to Dr. Rashmi Kahar, our moderator for this session. Thank you very much.
Thank you very much, Mamta Madam. It's really such a wonderful job by Maha Smiles, Bajaj Finserv, and Smile Train India that you are helping children with cleft lip and cleft palate. Thank you very much. And this project, special mention, I should mention that we have two visionary leaders. AMOGS has two visionary leaders, President, respected Dr. Rajendra Singh Pardeshi sir, and Secretary, Dr. Sujata Darvi Madam, and our complete AMOGS team. They have taken this project, and with your help, we will strive very hard to reach up to all the districts of the Maharashtra and create awareness about this very important health element. I would like to introduce Dr. Rajendra Singh Pardeshi, our President AMOGS, to the House. Sir is a true visionary leader. In Marathi, we say, "Bolu tesha chale, techi vandavi pavle." And he's a true example of that. And he is a very encouraging person to us, with many best paper award in national and international conferences, many research papers presented in national and international conferences. And he has been 2 times co-chairperson at FIGO 2016, and at many places he is faculty speaker in national and international conferences. And to his credit, there are many articles, scientific articles published. We welcome you, sir, to this webinar. I would also like to introduce our secretary, Dr. Sujata Darvi Madam. Madam is a very loving, cooperative, and a source of guidance to all of us. She's consultant obstetrician and gynecologist at Global Saifi Bhatia St. Elizabeth Hospitals in Mumbai, and Madam has been also joint associate editor of Jogi and clinical secretary of Mumbai Obstetrics and Gynecological Society. We welcome you, Madam. And we would like to have encouraging words from our President, Dr. Rajendra Singh Pardeshi, sir.
Good afternoon, everybody. Respected Dr. Mamta Carol, Senior Vice President and Regional Director Asia of Smile Train India. Dr. Sujata Darvi, our ever active Secretary of AMOGS. Dr. Rashmi Kahar, Moderator and Chairperson. Dr. Sujit Konkar, Dr. Padma Sani Venkatraman. First, I wish to express my sincere thanks to Maha Smile, Dr. Mamta Carol, for taking this initiative of awareness of cleft palate babies. As all knows, many children with cleft lip and palate may have a less attractive facial appearance or speech than their peers. A high incidence of teasing over facial appearance is reported among those with cleft lip and palate. As Dr. Mamta told, stigmatization and discrimination as the result of ignorance are prevalent. The need for public awareness should be emphasized to ease early apprehension about the defect and to promote early treatment to enable those affected by it to live healthy and productive life. We know the work of Smile Train India, and they are doing really excellent work in this field of cleft lip and cleft palate. With the expert speakers like Dr. Sujit Konkar and Dr. Padma Sani Venkatraman, I think this is going to be a great webinar and great awareness program. I congratulate Dr. Sujit Konkar, Chairperson of Fetal Medicine Committee AMOGS, and Dr. Rashmi Kahar, Chairperson of High Risk Pregnancy Committee AMOGS, for organizing this webinar with Smile Train India. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you. Over to Dr. Lakshmi. Lakshmi.
Thank you, sir. Thank you very much. We would like to hear from Dr. Sujata Darvi, madam, also. Shrutika, madam's there. Okay.
Sorry, Rashmi. Yeah, thank you, Rashmi, for a very kind introduction. As a secretary of AMOGS, I would like to welcome one and all for this inaugural webinar of Maha Smile, which is in collaboration with the Smile Foundation. This initiative was taken by none other than our president, Dr. Rajendra Singh Pardesi, along with Madam Mamta Carol from Smile Foundation. This is to bring about awareness about fetal anomaly like a cleft lip, cleft palate, which is easily treatable. Plus, one need to sensitize about this sort of a fetal anomaly. I would also like to go on record and appreciate the efforts taken by our fetal high-risk pregnancy committee chairperson, Dr. Rashmi Kahar, and Dr. Sujit Konkar, who is a fetal medicine committee chairperson of AMOGS, and he is also a speaker for today's webinar. I would also like to acknowledge the Dr. Padmasani Venkat, who is going to talk about how to take care of a children with a cleft palate and cleft lip. By those who have logged in, they are going to learn a lot and they will be sensitized about how to take care of a children with a cleft lip and cleft palate. I would like to wish all the best for today's webinar, and thank you so much for giving me an opportunity to address this august gathering. Thank you so much.
Thank you very much, madam. We promise you that through this webinar, we will try to reach to all the nooks and corners of the Maharashtra and create awareness about this very important topic. I would like to proceed to scientific session, and today we have speaker none other than Dr. Sujit Konkar, who is the chairperson of Fetal Medicine Committee, AMOGS, is an eminent gynecologist practicing at Sri Nursing Home, Aurangabad, and he is a secretary of Society of Fetal Medicine of Marathwada chapter. I would like to invite Dr. Sujit Konkar for his talk.
Thank you for nice introduction. I would like to share my screen. Yeah. Is it visible now?
Yes, it's visible.
Yeah. So at the outset, I would like to thank AMOGS President, Dr. Pardesi sir, Secretary, Darve ma'am, Smile Train, and Science Integra for giving me this opportunity. My topic is prenatal diagnosis of fetal facial clefts, all about imaging. This topic will cover only cleft lip and cleft palate and not complicated facial clefts, and this is limited to only mid-trimester period, not first trimester. So orofacial clefts can be defined as a failure to either completely merge or fuse in developing embryonic facial and palatal processes. Cleft lip is unilateral or bilateral opening in the upper lip between mouth and nose, while cleft palate is breach in the continuity of palate. You can call it as a furrow in the palate. It is a birth defect characterized by opening in the roof of mouth caused by lack of tissue development. So this is the incidence in various parts of the world. Maximum incidence is seen in Afghanistan. And in our setup, Indian setup, it is 1.7 per 1,000, which comes to 1 in 700, which is comparable to that of Downs and Talipes. So incidence of isolated cleft lip is just 25%, that of cleft palate is 40%, and cleft lip with cleft palate is 45%. Males are having more probability of having cleft lip and palate as compared to females, while isolated cleft palate is more seen in females. And unilateral, if you see unilateral cleft lip, it is more on left side. Various etiological factors have been put forward, like genetic predisposition, consanguinity, consumption of various drugs like anti-epileptic drugs, consumption of alcohol, exposure to radiation, various viral infections, various nutritional disturbances, deficiencies like folic acid, vitamin B12 deficiency, tobacco, chewing, smoking, various syndromes, or anything which cause the defective blood supply to that region is documented here. So what are the risk of chromosomal abnormalities in these patients, in these babies? So when there is median cleft, almost all are associated with holoprosencephaly, while least are associated with when there is isolated cleft lip, that is only 9%. When there is unilateral cleft lip and palate, only 5 to 15% are associated with chromosomal disturbances, while in bilateral cases, it is 15 to 30%. If there is associated cardiac anomaly, especially conotruncal anomalies, you have to think of 22q microdeletion. Micrognathia is supposed to be the most common association seen with cleft lip and cleft palate, which is associated with more than 270 syndromes. The common syndromes are Pierre-Robin syndrome, Stickler syndrome, and Treacher-Collins syndrome. Cleft lip and palate is one of the most common birth defects that pose significant medical, psychological, social, and financial implications on the affected families. The baby may face feeding difficulties at birth, swallowing difficulties, nasal regurgitation, hearing difficulties because of abnormal palatal musculature, speech difficulties due to nasal escape and articulation problems, and of course there is cosmetic problem is there. All this will be discussed in detail by respected Padma Sini ma'am. So prenatal diagnosis of facial clefts is crucial in order to plan delivery at a specialized center and to prepare the parents for the postnatal procedures. This is a simple anatomy of lip. This is the nasolabial creep. This is the central area of philtrum. This is Cupid's bow. The Cupid name is derived from Roman goddess, and upper vermilion border, lower vermilion border, and this is the lateral commissure. This is very nicely seen on coronal section of the face. And coming to palate, primary palate, it forms the 4 central incisions and extend up to foramen incisium. Here it is the foramen incisium, and rest is the secondary palate. It forms the hard palate, soft palate, and uvula. Classification. More than 15 classification systems have been there in literature. It is not as simple as unilateral, bilateral, or median. Various phenotypic deviations are seen here. This is very old from Brophy et al. Published in 1919. So at that time, this was the scenario. So this is so much complicated that then how to represent in our reporting. So you have to go by algorithmic approach. You have to go stepwise when you are imaging. That will come in latter part of my talk. So I'll just mention various classification systems. This is the Nagpur classification system put forward by Professor Balakrishnan. Then Davis and Ritchie is very old classification system. Then View classification. Then Lehschel system is also good. Friedman system came in 1991. Many sonologists go for this Nyberg sonographical system, type 1, type 2, type 3, type 4. But none of these systems are universally accepted. No one is in similar line with each other to talk about this classification system. But this system, Karnha's classification, is commonly used, most widely used. And here, the area affected by the cleft is labeled from 1 to 9, each of which represent the different anatomical structures as labeled here. For example, in case A, you see there is a cleft lip on left side. So this 4 number is shaded. In B, it is cleft lip on left side. There is alveolar defect as well as defect in premaxilla. So number 4, 5, 6, these are shaded in this Y. So this is how you should classify the defects. In embryology, this is one part which is very less welcome by delegates, but once you know embryology in a good way, you understand the pathology in a better way. So development of lip and palate begins around 4th week of embryologic development. It is completed by end of 12th week. By the end of 4th week, 5 facial prominences have formed. That is frontonasal processes, paired maxillary processes, and paired mandibular processes. So by the end of 6th week, paired maxillary processes grow medially and push the paired nasal prominences together. And fusion of the paired nasal prominences from the central part, that is philtrum, middle upper lip, nasal tip, and columella. And fusion of paired maxillary prominences with the paired nasal prominences forms the complete upper lip. The maxillary prominences form the lateral lip, and the lateral nasal prominences form the bilateral nasal ala. So failure of fusion of maxillary and median nasal prominences unilaterally or bilaterally results in unilateral or bilateral cleft lip with or without primary palate, and failure of the fusion of the palatal shells results in the cleft of the secondary palate. So if you see in this diagram, all the clefts are associated with these embryological fusion lines as shown here. So development of palate starts at 6 to 7 weeks of gestation. The medial nasal prominence form the primary palate, while secondary palatal shells are formed by maxillary prominence. Initially, tongue is between the 2 palatal shells, but after around 8 to 9 weeks, the tongue is displaced downwards and the palatal shelves fuse. One important point to remember here that even though palatal fusion is done by 9 to 10 weeks, ossification starts at 11 weeks and completes at around 14 weeks. So early in the early sonography period, that's from around 11 to 12 weeks, you may get maxillary gap on mid-serratal section. That is called as physiological maxillary gap. Don't jump onto diagnosing there is defect in the palate or maxillary line in that early period. So development of palate is different. It starts from uvula. So intact uvula, it's suggestive of cleft, patent cleft palate. No, you can say that there is no cleft in the palate. Presence of midline echo or visualization of nasal septum is indicative of cleft in the secondary palate. So coming to imaging, what does the guidelines say? It is the 20+2 plane approach suggested by ISOC. Here, it is clearly written that we have to look upper lip, nose, and nostrils. These are the minimum guidelines, and what you diagnose only cleft lip. This is the minimum which is required by a sonologist while doing your scan. So how to go for it? Those who are new to imaging and those who are into imaging but don't have this book, this is a very nice book written by Dr. Lakshmi Ravi from Krishnagiri district, Tamil Nadu. First and mid trimester ultrasound diagnosis of orofacial clefts. Every details are given in this book, and most of the content of my talk images are taken from Dr. Lakshmi ma'am's talk. So coming to basic evaluation of fetal face, here are these three basic planes. This is coronal plane. This is also called as node chin view. This is axial plane, and this is the sagittal plane. These three are the basic planes. So best view to assess the cleft lip is this node chin view or coronal view. You can see very nicely the allow of nose, columella, nares, upper lip, philtrum, border of upper lip. It is compared with the Cupid's bow, as already mentioned. So what we see in unilateral cleft lip, here it is the lateralized defect partitioning the soft tissue of the upper lip into two. One characteristic feature is symmetry of the nostril. See, this part of nostril is supposed to be falling down in the split. This is very characteristic. And another thing is, look for the extent of midline involvement. If the philtrum is also involved, you can label it as mediolateral defect. In bilateral cleft lip, the soft tissue of upper lip will be partitioned into three components. And excess soft tissue mucosa under the nostril, which is called as the median process. This median process appears as a premaxillary protrusion in the mid-serratal section. So here there are two clefts on either side of the median process. One more important thing is there should be minimal fluid between two lips for a good or better imaging like this. See this case here, there is no fluid. So you can actually, this is subtle. You see, there is subtle cleft lip there. You can miss this if there is no fluid as shown in this image. Another important thing is rule out umbilical cord and part of hand when you are suspecting cleft lip on your sonography. You can take use of color Doppler here. Coming to median cleft lip, it is the midline cleft or midline defect in the soft tissue of mass of upper lip. Here, there is absence of median process with non-visualization of the philtrum. See, bilateral versus median cleft lip. Here, there is presence of median process in bilateral cleft lip, and there is empty area, absence of median process in the median cleft lip, median cases. So, in mid-serratal section, you get very nicely this premaxillary protrusion, and this is suggestive of bilateral cleft lip. So, this is the comparison between two on mid-serratal section. You can see very nicely the premaxillary protrusion here, while here in the median cleft lip, there is part of nose is not seen. You can't see part of lip, philtrum, even premaxilla is not seen, even part of palate is also not seen. So this is a good view to comment on that. So most of the median clips, almost 100% of the median cleft lips are associated with holoprojun cephali. This is the depressed nasal bridge on the sagittal plane. This is flat profile. You can't see the part of nose here. Even palate is also not seen nicely. And this is the typical features of collocation cavity, that is uncluded ventricles and uncluded thalami and single ventricle. What next? You are diagnosed cleft lip. Good, you are good sonologist. What next? Is it sufficient? It is sufficient as per for diagnosing case or as per the guidelines, but it is not sufficient for those who need more information, for parents, for relatives, for pediatricians who are going to treat this case, or for orofacial surgeons or maxillofacial surgeons who are going to operate this case. Because up till now, you have diagnosed only up to lip. There is no comment on palate. So once cleft lip is detected, an extended evaluation of the facial critical face is necessary to assess cleft extension into the palate. And more importantly, when the families, those families where one member is having such a problem, cleft lip or cleft palate, or parents themselves are having this disease, so they are more anxious to see whether this baby is having that problem, or another factor is to know the rate of recurrence, whether it is some part of syndrome is there or not. So what are the reasons for difficulty in looking at the palate? Why it is difficult to comment on palate? See, this nose chin view will comment only on lip, not only comment. This sagittal view will give some information, premaxilla, hard palate is seen, but see this dense dark side. It is the shadowing of the palate. Because of this shadowing, you cannot comment on this area circled by this yellow. You cannot comment on soft palate. So 3 important problems are surrounding osseous structures which cause shadowing, then the dome-shaped structure of the palate, and third one is hard and soft palate. They are not in one plane. We will see one by one. So in the first trimester, the palate is flat, so it is easy to see, comment. But in third trimester, there are so many problems. It is hard osseous tissue giving shadowing. Again, it is dome-shaped, and another thing is tongue is nearby. It is obscuring the result, so it is very difficult. If you see in this coronal plane, you are going to miss this part. If you are looking at the mid-sagittal plane, you are going to miss this part. It is compared to this image. One may think that this elephant is like rope-like. One may think that it is like a tree. One may think it is like a snake, and so on. So we need some comprehensive information, and so many sections need to be taken to come on a point or on a good diagnosis. Again, there is a part called as vomer, which is a nasal bone attached to this parietal bone. It gives sometimes impression like a maxillary line or palatal line. See, in this image, in mid-sagittal view, apparently it looks good, a good palatal line, but if you see carefully, this is not the palate, this is the vomer in parasagittal view. Here, there is absence of palate. So vomer causes some problems in imaging. So what is normal then? This is a very nice article about superimposed line sign. This maxillary line is composed of 3 parts. This is premaxilla, palate, and this is vomer. So if you see this bifish structure, you are comfortable. So problem with cleft palate is unlikely, but it is not so in mid-trimester. So what are the tips to evaluate the secondary palate? It is very important. First and most important, fetal position should be such that the neck should be in slight extension. We are not used to examine babies in this position. We are used to a neutral position while measuring nuchal translucency for nasal bone and for measuring CRL. So this is very important. Neck should be in slight extension. The angle of insinuation should be 45 degrees at the palate. And third and important is there should be some fluid in oral cavity. All this needs patience, patience, and patience. You have to wait and wait and wait till the baby give good position. Fluid in oral cavity very, very nicely tells you the anatomy. See, this is extended position with a good angle, and see this fluid in oral phalanx. You see this is hard palate, soft palate, and this is equal sign of uvula. We'll come to that. Demonstration of uvula as equal sign. It is very, very important. This is seen in the transverse view. From BPD section, you go caudally to the oropharynx, you will get this equal to sign. An unremarkable uvula implies the presence of intact palate. And if uvula is deformed or absent, this might indicate a defect in palate. But again, there is another problem. Vocal cords also look like uvula. How to differentiate it? So take coronal section. This is the coronal section. So this is the vocal folds. These are vocal folds, and this is the uvula seen in this. And that is seen in 110 in coronal section, as shown in this video. See, these are the vocal folds, and this is the uvula. So see this. This is vocal folds, and this is uvula. But see this another in another image here. You can see very nicely the vocal folds, but this area is empty. So if you think that uvula is not there, absent uvula, you can't jump on diagnosis of cleft in the palate. It is just an indicator that there may be some problems. You have to go for extended views. So what are the extended views? This is the premaxillary triangle. The apex of triangle is formed by nasal bone. These are premaxillary processes, and base is formed by the palate. This is very important. This is normal figure, and this is in defects of the palate. See this. This is open palate. The base of palate is open. Another is alveolar arch. See, this is the seen in axial section. Very nicely, you can see this and see the defect. This is abnormal case. And another is bony posterior edge of palate. See, these things we do not see in normal patient. If the patient is high risk, if you know more information, you go for this. And this is very, very important. Bony posterior edge of palate. This is seen just posterior to this alveolar arch view. And this image shows very nice defect in the bony posterior edge of palate. Another important thing, the tongue is villain here. It obscures the image of the palate. See here, the defect is there, but because of this tongue, you can't see area behind this. It is a normal patient for just for demonstration. See this tongue, and this is the alveolar arch. This is the alveolar arch, and see, alveolar arch was there. This is alveolar arch, and see, this area, whole area is obscured by the tongue. So in this situation, you have to go for coronal sections of premaxillary triangle to comment on the palate. And most important, real-time swelling of fluid dynamics gives you everything, answers to your every questions about this. See, the extension is there, angle is nice, some fluid is there, and see, this is good fluid, this is hard palate, soft palate, and the equal to sign of uvula. This almost rule out everything, rule out every cleft of palate. And compare this with this video. This is tongue, very nicely seen. This is fluid, but you can't see the palate here. The oropharynx and nasal, oral cavity and nasal cavity, they are communicating with each other. And this indicates that this 100% there is cleft in the palate. The palate is not uvula. These two are the still images. So how to assess the cleft extension in unilateral cleft lip? How to go stepwise? What is the algorithmic approach? So this is the unilateral cleft lip. Next, see the alveolar arch. There is defect in alveolar arch. Next, go for premaxillary triangle. There is defect in base, and in sagittal section there is absence of secondary palate. So that was not just cleft lip. That is defect was in alveolar and secondary palate. Now another example. This is cleft lip, but alveoli is intact. So this is an isolated cleft lip without involvement of alveolar arch and palate. Another example. Cleft lip. See, alveoli alveolar arch is involved, but see here the premaxillary triangle is intact. Base is not involved. So this is involving only lip and alveolar. It is called as labio-alveolar clefts. This is the algorithmic approach given in that book, very nicely given. You have to start from nose chin view. If it is abnormal, then go for alveolar arch view, then go for premaxillary triangle, and then go for extended views like bony posterior edge of palate, visual sagittal view, or mid sagittal plane. So in palatal cleft lip and palate, see, this is nose chin view. Then alveolar ridge, there is defect. Premaxillary triangle, open base, cleft in palate, and the mid sagittal plane showing absence of secondary palate. So this is the diagnostic view to diagnose the cleft in secondary palate. This tells you everything. All the tips, all the parameters required are fulfilled in this image C. So this is the diagnostic view, but it requires patience. Baby may not give position very in easy time. It is not easy. Another pitfalls in imaging, the palate, two important one. This is the premaxilla and this is shadowing. So shadowing from premaxilla should not be misdiagnosed for left and secondary palate. And another, the echogenic upper border of tongue should not be mistaken as a maxillary line. So this is Homer, and there is absence of palate here. So this should be taken into account very seriously, should be examined very neatly, keenly. So in screening low risk patients, these two views are sufficient. No chin view and this summation of uvula equal sign. See, this demonstration of equal sign takes time. It is matter of experience. You start looking at this uvula from today in each and every patient in mid trimester. After a few patients, you will be mastered in that. And in high risk patient, you have to go for extended views like posterior ridge and this mid sagittal view, which is going to give you 100% diagnosis. So take home message, always go for basic pains. Fluid in oral cavity and avoiding shadowing from tongue and facial bones is necessary to characterize the extent of cleft. An unremarkable uvula visualized on USG as an equal sign suggests an intact normal secondary palate, and inclusions of signs proposed in sagittal, axial, and coronal planes helps in determining the extent of clefts. Thank you for being online.
Thank you very much, Dr. Sujit Konkar, sir. It was really an enlightening talk and in detail and very depth. It was a real honor to listen to you on this topic. Birth of a cleft child is really an emotionally distressing condition to the parents. And now you have opened a completely new chapter. We have this opportunity of forewarning patients or parents with USG diagnosis only. So thank you very much. It was very nice listening to you. There are two questions, but we will be taking those questions after the session. And I would like to invite our next speaker, Dr. Padmasani Venkatramanan, Madam, for her talk. I would like to introduce Madam. Madam is Professor, Department of Pediatrics, SRIHR Porur, Chennai, Tamil Nadu. Madam is Nutrition Advisors of Smile Train India and Coordinator of Indian Association of Pediatrics, Fellowship in Pediatric Infectious Diseases. She has many papers and publications and books to her credit, and she's also a co-chair of task force on care of infants with clefts at International Cleft Conference 2017. Madam is coordinator of IAP Fellowship in Pediatric Infectious Diseases, member Indian Academy of Pediatrics, member of Indian Medical Association, and member of Royal College of Pediatrics and Childhood from February 2005. It's a great honor on our part to have you, Madam, on board today. We welcome you, Madam, and would like to request you to kindly deliver your talk.
You are on mute, ma'am.
Sorry, am I audible now?
Yes, ma'am.
Yeah. Okay, thank you so much, Dr. Rashmi, for those kind words of introduction. Respected Dr. Pardesi.
Ma'am, if you could please speak a little louder.
Can you hear me now?
Yes, ma'am.
Okay. So my respects to all the dignitaries, Dr. Pardesi, Dr. Sujata, Dr. Sujit, Dr. Reshmi, and Dr. Mamta Carol, of course, an old friend. We listened to a very exciting talk about prenatal diagnosis from Dr. Sujit, and he has made my job a lot easy by giving an outline of the different types of clefts and the incidence of clefts. So I will start sharing my screen now. I am going to be talking to you about the early care of children with cleft. Is it full screen now? Has it gone into full screen?
Yes, ma'am.
Yeah. So, like Sir has already mentioned, an orofacial cleft is among the most common congenital anomalies that we are likely to encounter And the obstetrician and the pediatricians will be the first healthcare providers that the parents will meet. So it is important for us to be able to provide early care. Subsequent cleft care will come from a multidisciplinary team consisting of a plastic surgeon, a dentist, a geneticist, pediatrician and nurses, of course, nutritionist, orthodontist, otolaryngologist, and the speech pathologist. But early care has to be provided by obstetricians and pediatricians. The cleft may be unilateral or bilateral, or it may be a midline cleft. And this is a view from an intraoral view of unilateral and bilateral clefts. The reason I'm showing you these photographs is to understand why establishing feeding may be a problem in these children. The cleft palate may be complete or partial, or it may be a submucosal cleft. A very simple classification which we use at the bedside in day-to-day practice is the Nagpur classification. Group 1 is cleft lip alone. Group 2 is isolated cleft palate, and group 3 is cleft lip and palate. The incidence, as Sir has already mentioned, in India, it is about 1 in 700 live births. That means, given our current birth rate, every year 35,000 children with clefts are being born, and globally 2 lakh children with clefts are being born. So that is the magnitude of the problem that we are looking at. Most of us can expect to see at least 2 children with cleft every year. So when we talk about early care, my presentation will cover the counseling after a prenatal diagnosis.
Yes, ma'am. Yes, ma'am.
Yes. And timely diagnosis at birth, full assessment after birth, care for the immediate needs, airway and feeding. And after that, we can move on to the ongoing healthcare maintenance of these children. It is also very important on our part to give them anticipatory guidance and to be an advocate for these parents. Make sure that they get appropriate and timely referral to the correct cleft team. And we always have to act as a liaison between the family and the cleft team, because we are the people who are meeting these families more often. In fact, from the time they conceived, they have been meeting us. So we will be the contact person for them for any healthcare concerns. Prenatal diagnosis, Dr. Sujit beautifully explained. Usually a cleft lip or a cleft lip associated with a palate is diagnosed prenatally, but the status of the posterior palate is usually not known. So an isolated cleft palate may not be diagnosed antenatally unless the baby conveniently yawns during the scan. Any diagnosis of cleft lip is going to prompt the sonologist to screen for associated anomalies and for syndromic associations. And this should be followed by a frank discussion with the family. By frank discussion, I mean the family should be aware of what it entails to raise a child with a cleft, provided there is no other life-threatening congenital anomaly associated with it. After we have given information to the parents, we give them time to decide, and we are always going to be non-judgmental of their decision. It is up to the parents to decide whether they want to bring new life into this world with a cleft. Those who decide to continue with the pregnancy should get guidance about newborn care of a child with a cleft. And whenever possible, Dr. Mamta has already shared the toll-free number. We should arrange for a prenatal consultation with the cleft and craniofacial team. Much later, of course, comes genetic counseling. Is it a good thing to make a prenatal diagnosis? There are pros and there are cons. The good thing is that the parents are psychologically prepared, so it doesn't come as a shock to them. There is time to educate the parents. There is time to plan the care and feeding of these children. Of course, where it is applicable, it is possible to get verification of insurance coverage. If there is an indication, there is a possibility of getting genetic testing done. Futuristic, that's a potential for fetal surgical repair, not practiced even in the developed countries in a big way. And of course, it is sad, but there is the option of termination for the parents. On the other hand, it definitely increases parental anxiety, and it may lead to increased termination for a totally unnecessary reason. It is an eminently correctable deformity, but the parents may not have the courage to continue with the pregnancy. It is important for us to remember that these children, most of these children with a cleft lip and palate have an isolated anomaly. They do not have an underlying syndrome, and they do not have a higher rate of delivery related problems. So we do not have to refer them for delivery to a high risk obstetric unit. Most of them will be able to room in with their mothers. They do well in the newborn period, but what they do need is access to appropriate feeding equipment and support. So parents can be given information on which hospitals have these resources to support the feeding of children with a cleft. Usually the local or regional cleft team staff will be able to provide this assistance even over the phone. This is another thing I want to stress, because now that I have a chance to address obstetrician, an isolated cleft palate may not be identified at birth. A submucosal cleft child may be discharged from the hospital and may return later with feeding difficulties and overweight gain. So every effort should be made to visualize the palate during the initial newborn examination in the birth hospital for every newborn to exclude the presence of a cleft palate. In the immediate postnatal management, our focus is on airway management, establishment of feeding, a thorough head-to-toe examination for other congenital anomalies, and of course, psychological support to the mother. Very important. With good support, it is possible for her to establish a strong emotional bond with her newborn, but we have to remember that the mother is grieving at this point of time. She has lost her hopes of having a perfect, normal baby. So she will need support and encouragement. The other important thing is to not forget routine newborn care. I have seen newborn babies with a cleft being wrapped in a towel and being rushed to a tertiary care center. There is no emergency. These children, we can schedule an appointment with a cleft center whenever feasible, but the routine care can be given in the place of birth. We should not forget to give them vitamin K, provide warmth, and provide the birth immunization. Critical airway obstruction is usually seen only in syndromic clefts. And the commonest syndrome where we see this kind of airway obstruction is the Peary-Robin sequence. The airway is obstructed by the receding jaw, the big tongue, and the posteriorly placed tongue. And actually, it is the posteriorly placed glossoptosis that causes the cleft palate. It prevents the palate from fusing. This may be associated with a laryngopharyngeal reflux, which makes the feeding even more difficult. This critical airway obstruction may cause severe hypoxia and cardiac arrest. These are the different ways in which the airway can be managed at birth. Initially, we try non-invasive ways of managing the airway, prone positioning or even side positioning, like in this baby. Please note the small chin, receding chin, which is causing the airway obstruction. Most of them do well with prone positioning or side positioning like this. Sometimes you may have to insert a nasopharyngeal airway. You can even cut the endotracheal tube and attach the adapter to the cut end and make that into a nasopharyngeal airway. And some may require the support of nasal CPAP. If positioning a nasopharyngeal airway is not establishing the airway, then, and you find that you cannot maintain a good saturation, then these children may require endotracheal intubation, which is very difficult because of the glossoptosis and the retinogathia. Most of them will end up getting a tracheostomy. Children who are doing well with positioning may later require a lip-tongue adhesion. A lip-tongue adhesion is a surgical intervention which pulls the tongue forward and helps in opening the airway. Some of them with small mandible may require mandibular distraction osteogenesis. But these are not immediate interventions in the postnatal period. We have only these options for maintaining the airway. After we have maintained the airway, the next step is to establish feeding. It is very unfortunate that 1 in 10 children born with a cleft lip or palate die before their first birthday, and many die due to malnutrition because of cleft-related preoperative feeding difficulties. A simple intervention like proper feeding instructions can make a world of difference. This is a baby who first presented to us severe acute malnutrition, no major intervention, just good advice to the mother, teaching her the feeding technique, and the child gained weight and was fit for surgery in just 3 months. There are several reasons why these children have feeding problems. To be able to suck from the breast, we need a negative intraoral pressure, and these children are unable to generate sufficient negative intraoral pressure during suction. Also, because of the anatomic defect, the cleft palate, there is nasal regurgitation of the milk that goes into the oral cavity, and sometimes this may result in choking. So the baby has to pause. Because of the cleft, a tight seal is not possible, and these children end up taking excessive air. The air fills up the stomach and provides satiety, so the baby stops taking feed. So frequent burping may be needed to expel this air and allow the baby to continue with the feed. Definitely, this is not a very easy task. The baby may tire, and there may be maternal discomfort and exhaustion as well. The broad guideline is that use of breast milk should be prioritized. This milk may be given either directly to the baby or it can be expressed and offered to the baby. The second important thing is that the baby should be placed in an upright sitting or semi-sitting position to reduce milk flow through the nose. The kind of specialized feeding device to be used has to be individualized. The family has to be educated. They have to be reassured that milk will escape through the nose. It is common, it is expected, and it is not alarming. It does not indicate choking. And they should also be taught to burp the baby more often because these babies swallow a lot of air while feeding. I would like to reiterate the importance of breast milk in these children. Of course, the universal benefits of breast milk are well known. It has benefits for the family, it has benefits for the baby, it has benefits for the mother. There are nutritional benefits, immunological benefits, but more importantly, in these children, it is particularly beneficial because definitely whatever milk the baby consumes is going to enter the nasopharynx. And when you compare formula milk and breast milk does not irritate the delicate tissue of the nose and throat as much as formula milk. So it helps to tremendously reduce the risk of ear problems, which are so common in these children. There are several common feeding methods which have been tried for feeding these children. Direct breastfeeding using special bottles with special teats, cup and spoon, indigenous feeding devices like Paladai, Nifty Cup. Very rarely, when we are unable to offer food through any other means, we resort to using a nasogastric tube. But again, this is the last resort. Sometimes a combination of these methods may be needed. I want to once again reiterate the fact that feeding plates are no longer used. Feeding plates do not help in improving the nutritional intake of these children. They are a source of infection. Sometimes they even cause pressure necrosis of the palate. They are not in use any longer. Direct breastfeeding may be possible if the child has only an isolated cleft lip or a narrow cleft palate. But usually the cleft may cause a difficulty with forming a seal around the areola. Sometimes the breast tissue is able to mold the gap and establish a seal. The mother can even try holding the two sides of the cleft of the lip together. Just watch out for a hissing sound when the mother is putting the baby to breast. Hissing sound means air is entering the mouth. The mother may have to try several different positions before she finally manages to identify the position which is best for her and for her baby. And the nipple has to be always at the back of the tongue. It requires professionals experienced in feeding babies with cleft to support these mothers. They have a very important role to play. Regardless of whether the sucking is effective or not, we encourage all the mothers to put the baby to breast for 5 minutes on each side before every feed. Sucking is essential to infants, not just as a source of food, but also as a comforting factor. It promotes the bonding between the mother and the child. It helps in the development of oral motor skills. And most importantly, it stimulates milk production in the mother. So even if the baby does not have an effective suck, let the mother put the baby to breast for 5 minutes on each side. Only 5 minutes, not longer than that, because we don't want the baby to spend too many calories in the act of ineffective sucking. Once 5 minutes are over, encourage the mother to use a breast pump or a hand express the milk regularly. Regularly emptying the milk will ensure that she continues to lactate and produce enough milk for her baby. So whether it is the expressed mother's milk or a formula milk, it has to be fed through the baby. If the baby cannot take it directly, we can use either a cup and a spoon or a paladai. It is better to avoid bottles in our country because of the risk of contamination and infection. Every episode of infection is going to further compromise the weight gain. And if a bottle is used, it is also important to ensure strict hygiene by teaching the mother how to sterilize the bottle. A regular feeding bottle with an enlarged teat hole can be used, or you can make a slit. Ask the mother to not feed the baby for more than 30 minutes. One feeding session should not take more than 30 minutes. It is not at all unusual to find these exhausted mothers coming with failure to thrive babies saying that I am feeding the baby day and night. Don't feed the baby day and night. Baby needs rest. Mother also needs rest. Each feeding session should not last for more than 30 minutes. And if specialized bottles are available, you can consider using them after ensuring strict hygiene. There are several bottles available in the market, the Haberman feeder, the Mead Johnson's bottle, the pigeon bottle. Some of these are made out of soft, squeezable plastic that makes it easy for the baby to draw milk from the bottle with very little pressure. The milk is squeezed into the baby's mouth instead of the baby having to suck milk out of the bottle. A long nipple to press against the tongue with a Y cut at the tip of the nipple is recommended. This is actually designed, the Haberman feeder has been designed by the mother of a child with Peary Robin sequence, but it can be used to help any baby who has a weak sucking reflex. It has been used very successfully for some babies with major feeding difficulties. This is the Haberman feeder. The milk is stored here, but when you tilt the bottle, it comes into the soft squeezable part and it is easy for the baby to suck milk out of this portion. The feeding position is so important. Teach the mother to hold the trunk of the baby at 45 degrees angle so that most of the milk that the baby takes with the help of gravity goes into the stomach and very little milk comes out of the nose. This is another feeding device that is being actively promoted to feed children with cleft lip and palate. It is reusable, it is boilable, it is autoclavable, it is called the Nifty cup. It is like a measuring cup. You have gradations here which tell you how many ml of milk the baby has taken. It is made out of a soft silicone material, so it is comfortable against the mouth of the baby. And most importantly, there is a reservoir here for the infant to lap milk. This helps you to tilt milk into the reservoir and control the pace of feeding. The other advantage is that if the mother knows how to hand express, she can directly hand express breast milk into this cup and feed it to the baby. Our goals in supporting the feeding of these infants should be to promote breastfeeding, and if direct breastfeeding is not possible, to encourage feeding of expressed milk. The baby should be able to feed comfortably within a reasonable amount of time. During the feeding, there should be no struggle. There should be no struggle to breathe. There should be no choking or aspiration. Bonding with the mother is so important because feeding is a social activity. It should be pleasurable for the baby. It should be pleasurable for the mother also. And weight gain should be adequate. By adequate weight gain, What I mean is, the first 3 months of life, the baby should gain around 900 grams per month. And from the 4th to the 6th month, the baby should gain around 500 grams per month. Weight gain is very important because in most centers, the baby should be around 5 kgs for the lip to be repaired. This weight of 5 kgs can be easily achieved by the age of 4 months, 5 months, if feeding is adequate. It is also important to repair the lip as early as possible because again, it restores the appearance of the face and it encourages the mother to hope for a normal future for her baby. Oral hygiene is very important in the first few months of life. Babies do not produce much saliva in the first 2 months. And when there is a cleft palate, milk definitely will enter the nose during feeds. Breast milk does not irritate the tissues, but formula milk will leave deposits, and this can result in a chronically snuffy baby. So formula-fed babies should be offered, and sorry for the spelling mistake, should be offered 2 to 3 teaspoons of cooled boiled water after each feed. This is to remove the milk deposits in the nasal airway. They are also vulnerable to tooth decay, so good oral hygiene, cutting down on sugar, and regular visits to the periodontist is essential once the primary teeth appear. Like all infants with a cleft lip and palate should also have a newborn hearing screening before discharge. Newborn infants with a cleft palate, with or without a cleft lip, sometimes do not pass the hearing screen because they develop a middle ear effusion even while in utero. And this effusion is present at birth, causing the hearing difficulties. So even if the child does not pass the hearing, even if the child passes the newborn hearing test, these children require regular audiological evaluations as a part of care provided by the cleft team because middle ear effusion may develop anytime during infancy. Regarding complementary feeding, there is no difference in the timeline for a baby with a cleft. Complementary feeding should be offered from the age of 6 months. The texture of the food should match the baby's stage of development. It is very important to not delay offering semi-solid food because once the critical period is passed, it may cause problems if you introduce new foods. The baby may continue to reject new foods for several months, and the mother may have to struggle to make her child eat solid food. So it is best to start complementary feeding at the age of 6 months, like for any other baby. Just as we said for milk, this complementary food may also pass into the baby's nose through the cleft palate, and it can cause sneezing. The mother is likely to find this distressing at first, but keep reassuring her that there is nothing to worry about. And it is important to finish each meal with a drink of water to help to clear the food from the cleft area. The mother should be aware, the family should be aware of the timelines for cleft care. At birth, we check for airway maintenance, assess for associated anomalies, establish feeding, share a treatment plan. There are some children who will benefit from a pre-surgical infant orthopedics. The cleft care team will decide whether this is required to mold the development of the palate. Between 3 and 6 months, the baby should be immunized as per the national schedule. Monitor the baby for weight gain. Do a developmental screening, and when the baby reaches an appropriate weight, do the lip surgery. 6 months, give complementary feeding advice. 9 to 18 months, palate surgery if it is present. Between 6 and 12 months, periodic ENT assessment to rule out a middle ear effusion. Once the primary teeth appear, refer to a periodontist. And at 12 months of age, the child should meet the speech pathologist for establishing a follow-up routine. Beyond that, we monitor the growth of the child and we refer to a nutritionist if the growth is below the 3rd percentile. If there are speech defects, articulation correction is done by the speech pathologist. Around 5 years of age, these children may require surgery for velopalatal dysfunction. Between 7 and 11 years, they may require an alveolar bone graft. orthodontic treatment has to be continued. And depending upon the cosmetic outcome of the initial surgery, around adolescence, a lip nose correction or an orthodontic surgery may be required. The mothers are also keen to know what will happen to the feeding after the surgery. Individual circumstances will vary, but usually after a lip repair surgery, the feeding can be started soon after recovery from anesthesia. The feeding act does not damage the repair. But it is suggested that the bottle should not be used after a palate repair because inappropriate negative pressure on the suture line may cause the palate to break down and result in a fistula. So it is good to get the baby used to a spoon or a bottle or a trainer cup, a spoon bottle or a trainer cup before the surgery so that the child does not scream for a bottle after the surgery. The same may apply to a pacifier. It is better to get the child to give up the habit of using a pacifier before the surgery. So this is an overview of the care that the child requires in the first 24 months. Lip repair, palate repair, throughout psychological support for counseling, throughout attention to nutrition and feeding, speech language counseling and follow-up, and ENT care and dental care. All children with cleft do not require all these procedures. The individual procedures needed differs from patient to patient. This is an overview of all the care that these children may require. I have already summarized this in my previous slide. This is the procedures that may be needed after the age of 2 years till 12 years of age, particularly if there is a palate fistula that needs to be closed. Preschool rhinoplasty can be considered if the nose is highly disfigured. And of course, PPD surgery and alveolar bone graft at 6 years and later in life. Beyond 12 years of age into adolescence, they continue to require lip revision surgery, rhinoplasty, orthodontic surgery, and psychological support, speech therapy, depending upon what kind of articulation defects they have, and dental care. I had a video of feeding a newborn baby with a pala dye, but I'm not able to get it to play now. I'm really sorry for it. Let me see. This is just to show how indigenous feeding devices are so useful in trained hands in feeding these children without the risks of offering a contaminated bottle. So I would like to conclude by saying that support from all healthcare professionals, particularly the nursing staff and the lactation counselors, is critical. No feed should go on for more than 30 minutes because these long feeds cause exhaustion to the infant and the mother. They burn up too many calories and they impair the weight gain. Any amount of breast milk is useful because sometimes the mothers say, I hardly have any milk. Encourage her to give whatever milk she has. Let her give it as a tonic, even if it doesn't provide satiety to the baby, and monitor the weight gain of the baby. With this, I conclude my talk. I'll be happy to take questions. I once again thank the organizers, AMOGS and Smile Train for this opportunity.
Thank you, ma'am. It was such a wonderful talk, and we really had in-depth inputs from you. Thank you very much, ma'am. It's a real socio-economic burden on the society, and there are many intrinsic aspects of management of cleft lip and palate, and you highlighted and talked about it very specifically and very thoroughly. Thank you very much, madam. We would like to take questions on this topic for Madam Shrutika, if there are any questions. Shrutika, you have to unmute yourself.
No questions, ma'am.
Okay. So thank you very much, and it's my great honor to say a word of thanks to today for today's webinar. I'm thankful to Smile Train and this webinar in association with Maha Smiles, Bajaj Finserv, Smile Train India, and we are shaping smiles with in association with AMOGS, which is Association of Maharashtra Obstetrics and Gynecological Societies. And thank you very much, our respected President, Dr. Pardeshi sir, and Secretary, Dr. Dalvi madam, and team AMOGS executives, eminent speakers, Dr. Padvasami madam and Dr. Sujit Ponkar sir, and thanks to the team support of Smile Train. And I'm also very much thankful to Shrutika, Miss Shrutika, and Dr. Mamta madam especially. Many thanks to you, Dr. Mamta madam, and Shrutika, the very cooperative coordinator for this webinar. Thank you very much, and we would like to conclude. Have a nice time. Thank you so much.